Let's conclude kidney disorders. So let's wrap up peritoneal dialysis, and then we'll do the complications for both hemo and peritoneal dialysis. So let's review. So performing the exchange. So in peritoneal dialysis, the patient does this themselves. They or a caregiver can do this at home. An exchange has three parts. We have the inflow, which takes about 10 minutes. So after we have the catheter, after the catheter has been implanted, where is it? Never mind. So after the catheter is implanted, we have, wasn't there a picture? Oh, yeah, we did. Okay. So here's the catheter after it was implanted by the surgeon. Now it's ready to go. So the whole idea is using the peritoneal membrane as your semi-permeable membrane. This will filter out the fluids, excess fluids, as well as the waste products. But to do this, again, we need a lot of time. Yeah. So the patient has to do this continuously throughout the day. And in fact, they have one last exchange at bedtime. So this is the inflow. So they'll put in up to 2 liters of fluid into the abdomen. That takes 10 minutes to instill. They disconnect the tubing, wait 2 hours. So that's the dwell time. And then finally, after 2 hours, they will use the same bag now to drain the effluent, or this is now the outflow. How much again is expected to come out? If 2 liters went in, how much should come out? At least 2 liters, but do we expect more? Yes. What is that more comprised of? What else came out? Excess fluid, excess waste. Okay, so that's basically urine that's coming out. All right, because it has waste products in there. And then how many times do we do this again? 5 or up to 6 times a day. Okay, as many as the patient can tolerate. Now let's go now to the complications. Most serious complication with something invasive like this in your peritoneum is, of course, say the patient didn't wash their hands. So can bacteria be introduced into the peritoneum?
Yeah.
Is the peritoneum sterile? Is it a sterile cavity? The peritoneum.
Yes.
Yes, it is sterile. What about your GI tract? Is that sterile? So poop is sterile? No, the GI tract is dirty, but the peritoneum, meaning the sac containing your dirty abdominal organs, is sterile. That is sterile. So the procedure is invasive. You're putting, although the solution, the dialysate that you put in is sterile. However, contamination can occur and then can cause peritonitis. As with any other complications, what 2 things do we need to know? How do I know the patient is having peritonitis? So what do I need to know? How do I know it's happening? What are they for? What do I need to know out of this paragraph? What are those called? Signs and symptoms. Okay. So what are signs and symptoms of peritonitis? Well, fever is more like a late sign because fever indicates it's already systemic. So what are early signs and symptoms?
Cloudy drainage.
Okay, so that just like with a UTI, yeah, if your urine is cloudy, that means there's infection. Okay, so there's infection if the effluent, meaning the fluid that comes out, appears cloudy. What else? What will the patient feel if there's inflammation of the peritoneum? Is there pain? Yes. Will there be some rigidity in the abdomen? Tenderness. Okay. What's the intervention? Can they treat this themselves? So what's the only intervention? I'm having peritonitis, or I suspect peritonitis. So what's the only intervention? Can I get my own antibiotics? So what do you, okay, so report it to the physician. That's the only thing you do. They'll take care of the rest when you're hospitalized. Leakage. Leakage is not that serious unless a lot leaks, meaning the catheter stable if it's leaking? No. Can this lead to peritonitis? Yes. Bleeding. Now let's specify what type of bleeding are we talking about here. Okay, how much blood and how long is it ongoing? So bloody effluent must be observed occasionally, especially in young menstruating women. So is this expected if they're menstruating? Yes. Okay. What about here? Bleeding is also common during the first few exchanges after a new catheter, meaning this is the first week, for instance. Yeah, because it's new. Yeah. So your body hasn't adjusted yet. It's a new catheter. This is a new procedure. Yes, some bleeding is expected. But as this says here, bleeding is most often clears up after several exchanges. Okay. What if it continues after the first few sessions? Still bleeding. What do we do now? Same thing, you report it to the physician. Some things that aren't mentioned here. What if it looks brown? The effluent. What if it looks brown? Could that be poop? So what happened? What happened if you suspect, oh, why is this brown? It came in clear, now it's coming out brown. Looks like poop. So what happened? Could there be bowel perforation? Yes, maybe we've punctured the bowels. Okay, poop is coming out. All right, that's it for peritoneal. Let's go to complications of hemodialysis. Page 1580. All right, there are site-related complications as well as general complications of hemodialysis. Meaning, when we say site-related, what are the options we have for hemodialysis? What access do we have? How many access were there possible? There were three, right? We have the fistula, we have the graft, or we have the dialysis catheter. And then dialysis catheter can be tunneled or non-tunneled. Okay. All right. So here are most common complications: shortness of breath in between dialysis sessions, because can we do hemodialysis every day? I mean, do they typically do that? No, it's 3 days a week, right? Although if needed, let's say the patient has symptoms in between, especially the weekend, right? Because there's over the weekend, how many dialysis sessions will they, how many days will they go without dialysis on the weekend? 2. Okay, in between during the week, they have 1, but over the weekend, they have 2 days that they go without. So it's really a crucial time. So when will we expect more hospital admissions for dialysis patients? During the week or over the weekend? Over the weekend, it's very common. They come in, they'll stay for 1 to 2 days, just to catch up with the fluid removal, meaning they'll receive extra dialysis sessions in the hospital. Why can't they just go to a dialysis center? Well, again, they're not scheduled, so therefore, will the center take them? Not likely. And what do you think will be the most common life-threatening problem that they'll come in with? Knowing, understanding the whole concept of hemodialysis. Why did we do hemodialysis in the first place? What else? What else are we removing? Potassium and other waste products. Okay, so with potassium, is that life-threatening? What will they have? Hypo or hyperkalemia? Hyperkalemia. So that's usually the the admitting diagnosis. Okay, they have hyperkalemia, and then they'll, of course, we already discussed, besides dialysis, what are the other options to treat hyperkalemia? Okay, calcium gluconate. Okay, all right. Okay, all right. So there you go. Hypotension is very common because again, we're removing a little or a lot of fluids. A lot. And are we removing a little or a lot of the electrolytes? Also a lot. So muscle cramping, these are signs of not only fluid imbalance, but also electrolyte imbalances. Exsanguination, this is site related, meaning the needle came out of the fistula or the graft. Arrhythmias, again, from the rapid shifting of your electrolytes, specifically potassium. Air embolism, although not very common. Why does this seem like I've already done this before? We did this last week, yeah? I think we did. I think we did. Okay. All right. Something not mentioned here with the fistula. So you understand what a fistula is? Any questions about that? Can someone describe what a fistula is? AV fistula, I mean. So what did the surgeon do? Connected an artery in a vein. So maybe we have the picture here. Okay, we have it here. Here's the fistula. So when the arterial blood passes through here, does all the blood go through the distal portion? Since these two are now connected, are all the blood that's flowing through this go to the hand? Or do some of them go into the vein right here? Because they're connected now. Yes or no? No? All the blood will flow to the hand? You connected them. Can some of the blood be diverted and enter the venous circulation? Yes, yes, it will. Because the pressure, of course, will force that blood to enter the venous circulation. So now, what happened to the blood that was supposed to all go into your fingers of your hand? Some of them were diverted. So do you have full circulation in the hand? Okay, that's possible to happen. Okay, so there will be some decreased sensation, maybe a different color of your hand, or even pain. Okay, so we call that steal syndrome. Steal as in you stole something. Okay, S-T-E-A-L. We call that steal syndrome. Why is it called steal syndrome? What was stolen? Blood was stolen from the artery. Okay, so blood was diverted and entered the venous circulation. Okay, I think we can just see if we finish everything. Right, just a reminder, there are two charts for hemodialysis and the other is for peritoneal dialysis teaching, okay, patient teaching. This one, 48-10. And there'll be one for peritoneal dialysis as well. Okay, here. There is a automated option like this one. So let's say the patient can't do, this is under peritoneal dialysis. So let's say the patient is still working, right? So let's say Miss Chelsea is a working nurse and she needs peritoneal dialysis. Does that mean she can't work as an RN anymore? No, she can still work For working women like her or any other working patient, there's an option to do the peritoneal dialysis in an automated manner, meaning they'll do the exchanges, but when they get home to sleep, meaning they do like you do, work a 9 to 5 job or like say a 12-hour shift. When they go home, they connect themselves, their catheter to this time it's automated. Okay, so the machine will perform the exchanges. Okay, not manually, not like the ambulatory CAPD. This one is done by a machine, okay, when they sleep. So they just connect it, go to bed, sleep, and then disconnect in the morning. Okay, it's automated. That's an option. And here's the one for the teaching for all peritoneal dialysis options. Now, a few things I want to emphasize here. In peritoneal dialysis, unlike hemodialysis, wherein it's 3 days a week, this one is continuous, yeah? With this option, the patient actually loses protein during peritoneal dialysis. Because of that fact, are we restricting this patient's protein intake? I repeat, the patients during peritoneal dialysis with this option, because the peritoneum is more permeable compared to the dialyzer in the hemodialysis machine, the patient actually loses proteins. They lose proteins during peritoneal dialysis. So the question is, are we restricting these patients' protein intake? No. In fact, we increase it because they're losing protein. Okay. So we actually expect more protein intake if a patient is on peritoneal dialysis. All right. Any questions on dialysis at all? So what do we do again with the vascular access? Fistula, especially fistula. What are those precautions again? So basically you have a vascular access, okay, a fistula or a graft in the arm. So what do we do with that arm? Yeah, you worship that arm like a god, okay? Protect it, okay? Treat it like a princess, okay? So this is the golden arm with the fistula. Okay, so we need this, so protect it, no blood pressures, nothing constricted. Yeah, no constricting jewelry, clothing, including blood pressure cuffs or tourniquets. All right, nothing whatsoever. And what are the two things we monitor again and we make sure is present? Okay, the bruit and the thrill. Okay, what is a bruit again? Okay, the sound. The thrill is the vibration. Very good, children. Okay. So a few questions. If a patient is on hemodialysis, or let's say CKD, so you know these patients are in what fluid status state? They are mostly in fluid overload. So how do you react if a doctor orders IV fluids on these patients? Okay, you can clarify, but let's say they tell you, oh, yes, we understand he's in CKD, but they are also in acute kidney injury. Okay, meaning they have AKI on CKD, okay, which can happen, right? I mentioned that last week. So can they receive IV fluids? Let's say it's pre-renal AKI. Yes, they can, but make sure though, because can we give fluids indefinitely? Okay, so how do you know we've given enough? We discussed this 3 weeks ago. What do we monitor again? Okay, all those indicators we discussed in week 1. All right. Because you'll see this a lot because CKD patients, can they suffer AKI? Yes, they're likely as predisposed as any other patient. Okay, even in a CKD state, they can have pre-renal, intra, or post-renal AKI. Right, about blood pressure. So let's say I'm scheduled for dialysis today, hemodialysis. And what did we expect again? These patients are on a little or a lot of blood pressure medications. A lot. Okay, so we're expecting beta blockers, calcium channel blockers, diuretics, ACE inhibitors, okay, you name it. What do I do with those medications if they're scheduled for hemodialysis today? Knowing that, what is an expected effect of hemodialysis on blood pressure? It will lower it because of the fluid removal. So what will be my responsibility when these patients are scheduled today and I have like 5, 6 of them to give? Okay, none of them will be given. Okay, your decision as to whether or not to give it is actually pretty simple. What will hemodialysis remove? Fluids, what else? Electrolytes, waste, and medications. Okay, so can medications be removed during hemodialysis? Okay, so that's therefore, do you give these medications? You're wasting the medication, okay? Because they're going to be dialyzed anyway. When in doubt, what do you do? When in doubt, let's say you're not sure which medications to hold. You call the doctor. Okay, when in doubt, okay, hey, I know I'm supposed to know this, but can you just give me orders? Okay, they'll be happy to. Okay, infection, how will they sustain infection? From, is this invasive? What do we consider the catheter again? The IV access? These are all portals of entry. Okay, so they are at risk for infection. Okay, we already discussed the care of the catheter site. This is both for hemodialysis and also peritoneal dialysis. Okay, we just discussed the medications and your role. Okay, that's the end for AKI and CKD. Let's take a short break.